Um, Thank you all for being here. I missed the first primary care provider symposium last year because I managed to catch COVID for the very first time last year. So this is, we've been talking with different folks throughout the day here, and one of the things that I said earlier to the primary care physician who's sitting at my table is we've done a lot of different things as we've launched this Georgia MemoryNet initiative. And I think the things that we've done successfully early on, setting up the memory assessment clinics, the diagnostic assessments, linking partnerships with the aging services and DPH and state partners is something that we already kind of knew how to go about doing. But one of the challenges that I think is going to be our biggest challenge long-term in the long-term sort of battle against Alzheimer's and related dementias is with all of you, with the primary care providers throughout the state. You've seen the numbers. There's no way that we can grow Georgia MemoryNet sufficiently to provide care for all of the people that are going to need care. And so the fact that you all are here today is fantastic. The fact that we're making some progress in forging partnerships and extending these working relationships is really heartening. So thank you for being here. What I'm going to do, this is, I think probably Chad and I both really enjoy doing this part of the presentations the most because it's so exciting. So what's been happening in our field in the last couple of years is just remarkable. I know it's, you guys, anybody remember who Doogie Howser was? You guys remember Doogie? So I'm Doogie, so I've been around for 25 years or more doing this work because I started so young. But the advances that have come along in the last few years is what we've been looking for 2, 3, 4 decades for those people who've been in this field. And so it's really exciting to talk about this. So just a very brief background, because you've already heard a lot of this, but I want to just point out one thing specifically in this slide. So there are lots of places where we have urgent needs, and you know what those are. The lack of access, lack of support for aging in place, some of the return on investment we can do with better management. But truly, for me, the motivation for starting this effort was because we knew this was coming. When we started this effort pushing for this back in around 2010, when things started moving in the legislature in 2015, 2016, 2017, we knew this was coming, but even though we knew it was coming, we still got caught, not quite prepared. And that is that we have therapeutics that are only going to be applicable if you identify specific causes of cognitive impairments and dementia early enough. And so if you can't catch it early enough, or you can't implement treatment early enough, those patients are not going to benefit. And this is a major, major hurdle that we still need to overcome. The numbers are what they are. We know that the burden is increasing everywhere, but it happens to be increasing more rapidly in Georgia than in other states in the country. Lucky us. And let's just make sure that we're all on the same page in what we're talking about. So you've already heard from Stephanie and others, from Chad, that Alzheimer's is just one particular disease, and we're talking about symptoms of mild cognitive impairment and dementia, which is just on a spectrum. In fact, I've started to think that mild cognitive impairment as a syndromic entity has sort of run its course in terms of benefit to our field because it just confuses people. What is mild cognitive impairment? It's cognitive decline that's not normal. How's that different from mild dementia? Well, your FAQ might be 6 instead of 10. I don't know. It's on a scale from very, very early symptoms that are hard to discriminate from normal healthy aging, that is a persistent decline from a normal baseline, whether it's MCI or dementia. MCI individuals tend to be independently functioning in almost all areas, sometimes still winding down medical or legal practices, running businesses. whereas when things progress to a point of mild dementia, there's a little bit more limitation in instrumental activities of daily living, and then as things progress, more profound impairments. But really, it's just a progression of symptoms, and that's all we're talking about. We're not talking about a specific disease when we talk about dementia or MCI. And when we talk about Alzheimer's disease, we have different versions of this pie chart. I've modified mine, so if some of you think, hey, wait a minute, that red thing was something different last time, don't worry about it. But when we talk about Alzheimer's disease, we're talking about a very specific disease with specific underlying pathology, underlying pathology with plaques and tangles, which we'll talk about more. But there are other conditions, including vascular injury to the brain, that can be associated with cognitive decline. These are something called Lewy bodies and Lewy neurites that are associated with Parkinson's disease and dementia with Lewy bodies. And then there are other pathologies, including something called TDP-43 that's associated with certain forms of frontotemporal dementia and a relatively new entity called late. But Stephanie alluded to this earlier. In fact, many of these cases are mixed etiology dementias. And one of the challenges for the field going forward is going to be to personalize our diagnosis and management of patients so that we're not taking Alzheimer's disease and assuming everybody who's diagnosed with Alzheimer's disease has a monolithic disease entity. Because very often there's overlapping pathologies. And when you look at case series, there are about 10% of patients who are diagnosed with Alzheimer's disease that have only hallmark Alzheimer's pathology. The rest of them have combinations of Alzheimer's pathology with alpha-synuclein and Lewy bodies or TDP-43 or vascular changes. So very complex mixture, but we're learning and we have additional challenges. But the major advances in the last few years has come in this area, and this is it's a famous image of Frau Auguste Dieter, who was the index patient for this fellow, Alois Alzheimer. And she came to attention because she was very, very young when she showed signs of senility, things that people have known about since antiquity, but she was felt to have a very rare disease because she was brought to the hospital by her husband at age 51. With typical symptoms of Alzheimer's disease that we recognize with memory problems, persecutory delusions, progressive decline. And she died at the age of 55. And then Alzheimer's studied her brain after her death and described these pathologies. And that's been sort of the mainstay of this field and the focus of our efforts to develop treatments for over 100 years. And we've made some progress. Initially, some of the important progress was in diagnostics. So any of you still believe that you can only diagnose Alzheimer's disease after somebody's dead and you can look at their brain under a microscope? Come on, fess up. Somebody said that to somebody recently. It used to be true. It is no longer true. And one of the earliest ways that we developed to diagnose Alzheimer's disease as an etiologic entity, recognizing the presence of those neurofibrillary tangles and those amyloid plaques, was in doing spinal fluid tests, doing a lumbar puncture, which we do a lot of because that fluid is in direct contact with the brain. And we can measure proteins that are associated with amyloid plaques, the amyloid beta protein, and tangles, the tau protein, the microtubule-associated tau protein. And under normal conditions, levels of the amyloid protein tends to be fairly high, while levels of the tau protein tends to be fairly low. So when you see that pattern, that's a normal pattern. But in patients who have Alzheimer's disease, the levels of amyloid protein in the spinal fluid is lower, and the levels of the tau protein is elevated. So when you see that, you can say with a very high degree of confidence that that person will have amyloid plaques and neurofibrillary tangles in their brain. And so this is something that we've used for many years now, even in advance of the availability of specific Alzheimer's disease modifying treatments, because it provided very valuable prognostic information. So there's a lot to managing patients with Alzheimer's and related dementias that go beyond medication management. You've heard a lot about that in terms of some of the support needed by patients and family members and caregivers, but also Think about financial management. So how many of you know somebody who lost a lot of money because they got swindled by that Nigerian scam or some other uncouth individual who came and sold them $3,000 worth of yard services? And so understanding what's going to be happening in the future is important. And so when we look at the spinal fluid profile of somebody who has mild cognitive impairment, and remember that just means they have some mild difficulties, what you can identify are people who have an Alzheimer's-like profile and those who have a normal profile. And those who have an Alzheimer's-like profile, over the course of about 5 years or so, you can predict with virtually 100% probability, in the absence of other interventions, that that person is going to progress from a functionally independent mild cognitive impairment stage to at least a mild dementia stage. Whereas somebody who has a normal spinal fluid profile has a less than 10% probability of progressing during that same time frame. So we use this a lot for prognostic information, because if you know that a person has mild cognitive impairment, but you can rule out Alzheimer's disease, their prognosis is much, much better. And so planning and for older adults, trying to figure out what needs to be thought of in terms of contingency planning and expectations going forward was already valuable. But now, with the advent of newer therapies, being able to identify the specific underlying etiology early on becomes even more important. And there are other modalities that I'm sure you've heard about. So there are amyloid PET scans now. And these are 5 different individuals who've had dye injected, and this is a specific dye that goes into the brain and will stick to amyloid pathology. So what you're looking at here on this leftmost column is nonspecific. So this is I don't really like this tracer. We don't like reading these scans because it's stupid. This is all nonspecific. So this dye likes to go in and stick to white matter. And so when we look in the white matter, we'll see a lot of signal in a normal individual. But what happens with the accumulation of amyloid pathology, the signal starts to stick in the neocortical regions in the gray matter, and that's where all of this warm red and yellow signal comes in. So you can now directly visualize Alzheimer's pathology in living humans using these amyloid PET scan technologies. And all of that has taught us that Alzheimer's disease is no different from heart disease, colon cancer, breast cancer, or any other chronic condition. And you saw, I forgot who showed this slide. Did you show this slide, Chad? I think Dr. Hales showed this slide this morning. And what we know is that these pathologies are evolving up to 20 years before somebody develops symptoms of mild cognitive impairment and progressive dementia. 20 years. So there's a progression of this pathology, and this is really important. This is critical. It's already important to recognize that on average, Alzheimer's disease progresses from the initial manifestation of short-term memory loss and mild cognitive impairment to late-stage severe illness in terminal stages over the course of about a decade. So it's already a long, drawn-out process, but now we're talking about an additional 2 decades of silent disease evolution, which is an incredible opportunity. And that's the way that we look at this now as we have come to understand Alzheimer's disease as a chronic disease. This is a slide, I swear, I think I might have created this in the previous millennium, this slide, and I have not changed it. And this is because of what we learned in the 90s about Alzheimer's disease mechanisms. This hypothesis, this amyloid cascade hypothesis, came to be dominant in the field. And the hypothesis says that there's something related to the accumulation of this amyloid pathology that triggers a whole cascade of events that ultimately leads to dementia and functional decline and limitations. And a critical corollary to that is, if that's true, if this is causal, then doing something about the amyloid should do something about the disease. And it's taken us, so that was back in the, I guess that was probably back in the late 80s or early 90s, maybe mid 90s, that hypothesis had come to dominate the field. And over that time, a number of different strategies have been implemented, and this is the one that now has really become a major advance clinically. And that is to target this amyloid protein that accumulates in these extracellular accumulations of plaques. So what happens is this little fragment of a precursor protein that gets cut out of the precursor protein. Normally, it can just be soluble. It gets cleared away. It doesn't cause any problems. But it may also be produced as a slightly longer form of this amyloid beta peptide, which tends to stick to other amyloid beta peptides, creates these what are called soluble oligomers, and then protofibrils. They get into larger fibrillar stacks and then ultimately accumulate in these large accumulations of extracellular protein. All of these crazy names and numbers and letters are different antibodies that have been developed targeting these forms of amyloid. And that has been the strategy. Actually, the very first strategy was an active immunization treatment that was initiated back in 1999, was the very first effort to try and clear out this amyloid using the immune system. But what's happened over the last 20 years now is that we've developed better antibodies. And what you're looking at here are a series of patients, 5 different patients, 1, 2, 3, 4, 5, who were all treated. So these are their baseline scans. And these patients were all treated with an anti-amyloid antibody. And I think this one might have been gantenerumab. It's not one of the 2 currently FDA-approved ones. But what you see is over time, I think this was a 2-year span, over the course of 2 years of treatment with this particular antibody, you went from a lot of Alzheimer's amyloid to be cleared out to now basically you're just looking at that stupid background staining in the white matter. So these antibodies will very effectively remove the amyloid pathology out of the brain. It will literally clear it away. The red is the amyloid, correct. I think that one was gantenerumab. There are several different antibodies that do this. Aducanumab did it, lecanemab did it. Did you have a question too?
Yeah, do you see improvement in clinical symptoms that are correlated with the change in the...
Great question. So there was, I think some of you remember the controversy with the very first FDA-approved drug in 2022, a drug called aducanumab or Aduhelm. And FDA kind of jumped the gun. So there were 2 phase 3 trials of aducanumab that in both instances effectively cleared out the amyloid. One study showed clinical benefit to the patients treated with aducanumab versus placebo. The other one did not. FDA said, well, that's good enough for us. And they gave approval, initially accelerated approval and then standard approval. And there was a lot of controversy. And CMS said, OK, that's fine, but we're not going to pay for it. And Biogen was marketing this drug at $56,000 a year. So it's basically been dead in the water since CMS made their decision about covering the cost of the drug only in the context of clinical trials. But the same time that they made that determination, they broadened that discussion to discuss coverage for all anti-amyloid monoclonal antibodies. And so what they said at that time when they declined to cover aducanumab was that if a drug shows evidence of amyloid clearance and clinical benefit, we will pay for it. And you just have to meet some lesser criteria for getting coverage. And that's what's happened now. The first drug, Leqembi or lecanemab, was given standard FDA approval in July of 2023. And the same day that FDA gave standard approval, CMS said, OK, we'll cover it under those conditions that we defined last year for aducanumab. And then this year, almost exactly 1 year later, Lilly's drug, donanemab, also received standard approval and is now covered. So now you have 2 monoclonal antibodies to amyloid that are FDA approved and covered by Medicare and most insurance companies. Cigna, I believe, is the one butthead insurance company that has said that despite all the evidence to the contrary, it's an investigational agent and they won't cover it for any of their patients. but all of the other companies that we had to deal with are covering it. They make you jump through some extra hoops. So what was the evidence? So these are the data from the lecanemab phase 3 trial. And you see that compared to placebo-treated individuals, the drug very rapidly clears amyloid. And basically, after about a year and a half of treatment, the majority of individuals had no detectable amyloid left on the PET scans. And what you saw during the trial was that people who were treated with drug had a 27% less decline compared to people who were treated with placebo. And there's a lot of discussion. Somebody earlier was talking about risks and benefits of drugs and what that means. And this has been an ongoing question. One way to look at this, and I'll come back to this particular point, if you say, well, what does that 27% mean? It's not like it stopped it. It's not like you made me better. You didn't make me younger and prettier and skinnier. You didn't do any of those things. You just slowed me down by 25, 30%. And that's the evidence for all of these drugs. That's the equivalent of about 6 months compared to placebo-treated individuals. People who got active drug across all of these metrics basically had about 6 months of extra time. And we'll talk more about what that means as well. But it's not for everybody. So let's talk about, that's the benefit. Let's talk about the risk. There is something called ARIA, which stands for amyloid-related imaging abnormalities. And I don't remember why, but I happened to pull a series of scans from some of our patients. And this is a patient who was treated with lecanemab. This was the baseline scan, and there was just the tiniest bit of maybe a little bit of starting of mild edema, but all of this white is extensive edema associated with the use of this drug. I think for this patient, she might have had paused in her treatment for a couple of months, but then resumed treatment. The ARIA was asymptomatic. This didn't cause any symptoms. I'd be willing to bet that if I had examined her here, she would have had some visual field problems, but she didn't have any clinical symptoms that she was complaining about. And over the course of the next 3 months, it completely cleared away, and she's continuing to get treatment now. And this is typically what happens in those patients who develop ARIA, and we'll talk about the frequency and so on. This is another patient. This is one of my patients. This is her baseline MRI scan, and she's a 67-year-old who's E4 homozygous, and this will become important in a minute. On her baseline scan, she already had 1 or 2 little microhemorrhages. So this yellow arrow is pointing to a black dot, which is the hemorrhage, the brain bleeding that we hear about with these drugs. But she was E4 homozygotes have a much higher risk of developing these problems. And this was her scan after just 2 doses of lecanemab. She developed this massive area of bilateral edema, and you can see also a bunch of new little black dots representing new microhemorrhages. And it gradually got better, but it was pretty bad. And the microhemorrhages, when they occur by themselves, they don't tend to cause a lot of symptoms, but a lot of times you'll see these microbleeds occurring in the context of this swelling. Hers was bad enough, it scared me. I took her off a drug, and she's not getting it anymore. We've had a total of 2 patients out of about 150 that we've had to actually stop treatment on. But by and large, with adequate safety monitoring, these drugs can be managed. I mentioned the ARIA. The ARIA incidence overall in the lecanemab trial was about 25%. And here you're looking at placebo treated in the red and lecanemab treated in the blue. And this is interesting. The patients who were treated with placebo, 9% of people on placebo developed those microhemorrhages. And I've got kind of blah about the bleeding concerns because when they occur in isolation, they never have any symptoms. And people who are on placebo can just spontaneously develop these. but much higher rates in individuals with treatment. And then the ARIA-E, the swelling, the edema, is way, way higher in drug-treated individuals compared to placebo-treated individuals.
Dr. Lau, I'm sorry. You said that you treated 100 patients with oral levels of FOE?
No. So I don't know how many, Chad, do you know how many E4 homozygotes we currently have? 10, 20? So
So despite that, you're still offering that?
yeah. So we do an extra, so the question was about ApoE4 homozygous individuals. We don't have 150 ApoE4 homozygous individuals. We're not precluding them from treatment, but we take extra precautions because of exactly this. So there are some institutions, including the VA Medical Center, that's decided that they are not going to treat anybody who's E4 homozygous with these drugs because of the higher risk. And the higher risk is quite substantial. So we call this ARIA, amyloid-related imaging abnormalities, because most of the time they're imaging abnormalities, and they're asymptomatic. They're just things that you see on MRI scan, but they can be symptomatic. Overall, the rate of symptomatic ARIA, and they might be mild headache, unsteadiness, things like that. In people who don't carry an E4 allele, the rate of symptomatic ARIA, the imaging abnormalities associated with some neurologic manifestation was under 2%. But if you have 2 copies of ApoE4, the rate of symptomatic ARIA approaches 10%. So really important consideration when you factor in ApoE. We do this, we require ApoE testing in anybody that we're starting on these treatments not because we're not going to preclude them from being treated, but because we want the patient and families to know that there is a substantially increased risk and factor that into their decision making. So let's go back to this question of this 27% slowing, what is that worth? So I mentioned about a 6-month savings in time. So what you're looking at now is stepwise progression. So people had evaluations every 3 months. So this is the progression from an earlier stage to a later stage of disease. People on placebo and people who are on active drugs. So this might mean going from mild cognitive impairment to mild dementia on something like the CDR scale, going from 0.5 to 1, but looking at progression to the next stage of disease. And so if you map that out, over the course of the 18 months of the trial, you're stabilizing people at an earlier stage for about 6 months. But remember, this is just during those 18 months of the trial. So during the 18 months of the trial, if we just kind of change this to hypothetical lines, a placebo-treated individual progresses like this, and then drug-treated individual progresses slower, so that you bought about 6 months of time during those 18 months. But if you continue treatment out, what you can anticipate is that if this is not true, because dementia doesn't decline in a linear rate like this, but we're just doing this for simplicity. But if you map that out, the longer you go out, so when you go out beyond the 18 months, the hope is, the anticipation is that there will be continued separation of these lines so that people will continue to progress slower and gain even greater benefit. One important aspect of this to think about is that time is brain. So we've said that forever with, time is brain in terms of stroke. Time is brain, even though not with the same acuity in these dementing conditions. So when you take these people who are started on placebo, after 18 months, they had the option of going on open label extension, and they too started declining slower, but you never make that gap up. So the earlier you start these individuals, the more likely they're going to benefit over the longer term. So I think when you look at it like this, when you look at it like that, the issue of what do you gain from that 27%, now I've done it. What do you gain from that 27%? That may be just 27% here, but the benefit is what you anticipate further out. And this is sort of places where we don't have data yet, but I think it's meaningful. All right. I'm not going to talk about this a whole lot, but this is, I saw during one of the questions, none of you guys was real interested as primary care providers in ordering a bunch of Alzheimer's diagnostic tests. I can't imagine why. But this is coming, and we're going to have to figure out, this is going to be one of our challenges in the coming years, is to figure out how to build this into our care planning and our management. And this particular, in a field that's moving incredibly rapidly, this field of blood tests is moving faster than anything I've ever seen in 25 years in this field. And the tests are now available. So this is a list of all of the commercial tests that are now available looking at these different measurements of phospho-tau 181 and phospho-tau 217, 231, there's a couple other ones. But the p-tau 217 is clearly head and shoulders above the other measurements. And the AUCs, so predicting Alzheimer's versus control on PET scan using the results of the plasma p-tau 217 is incredibly accurate. And so this has rapidly become sort of the dominant blood test that's available. We've started using this in a handful of cases. We're still trying to figure out how to make the most use of this. It's not covered by insurance. One of the early plasma tests from C2N was about $1,200 to $1,500. You can get the p-tau 217, where our lab sends it, you can get it for about $260. So patients have to pay for it, but that's not so expensive that nobody can do it. And so we've started ordering this on a few people. And where I think this is going to come into play is in making our process of streamlining those patients, identifying and streamlining those patients who may benefit from these emerging therapeutics without a 5-year delay in getting their evaluations done. And so maybe this gets done as a blood test in the course of primary care evaluation. We'll have to make sure that we understand how to do that in a way that is doable for you so that you can actually do this as primary care physicians without having to spend an hour. You know, as somebody was saying that if somebody screens positive for cognitive issues, they usually don't try and talk to them about that at that visit because you know, you've already talked about 5 other things during that 12, 15-minute visit, and you can't really talk about Alzheimer's disease and walk out of the room in 10 minutes. And so we have to figure out how to do this, but I think we can figure out how to use this in a process. And also, as it gets better and better, people are going to start using this as opposed to spinal fluid or PET scans as a diagnostic. I just learned this week that one of the upcoming Lilly trials where they're testing anti-amyloid treatments, they're just going to do the phospho-tau 217 for their eligibility screening. They're not going to do amyloid PET scans. They're going to qualify patients strictly based on the phospho-tau 217. So it's really getting very close to that point. So there's going to be a lot more to come about blood tests and how we use that, especially once insurance starts covering these tests, because that's going to happen. All right, so this is, so this is just one example. So I had a patient, one of the first ones that I ordered this on, he was a 76-year-old guy with occasional forgetfulness. He had a strong family history in his mom, and on her side of the family, he was completely independent. Neither he nor his wife were expressing high levels of concern, but he did have isolated memory impairment on testing. And so we said, all right, well, let's go ahead and do this. And then if it's negative, we can feel reassured. And then if it's positive, we can figure out what else we need to do. I was expecting it to be negative. And so the Mayo lab that does our ALZpath 217, they defined 2 different thresholds for negative and positive to magnify to amplify the sensitivity and the specificity. So they set a threshold of 0.185 as negative to get a very high negative predictive value and a higher level for a very high positive predictive value. It leaves you with this annoying gap. And I can tell you I've gotten a couple of these annoying gaps that fall right in the middle of this. And so it doesn't really help you, and you wind up having to do the regular testing anyway. My guy was clearly positive. I wasn't expecting it. His MRI, I can tell you, is normal. I haven't done his LP yet. But again, this is a guy who is a great candidate for these anti-amyloid treatments. And so, it may be that in years past, I might have said, well, you didn't do so great on this memory test, but you're doing great. Concerns aren't that high. Let's just see how you look in another year. And then we might have lost another year or 2 years before we actually landed on treating with anti-amyloid monoclonal antibody. When there was no such option, it's not that big a deal. But now it is a big deal. Time is brain. So last section, I'm going to talk about something that some of you smart folks have recognized and say, well, Jim, what the hell? You said there's like a 20-year gap where this crap is in there. Why are you waiting until people get sick to treat people? We shouldn't. And we're not going to. And this is some of our data from actually the wonderful physician who's sitting at my table as part of this study in something called the Emory Healthy Brain Study. And what we're doing here is we're looking at individuals who are cognitively normal over the age of 50, between 50 and 75 in enrollment. And we're trying to figure out how to predict who's actually going to get sick. But what this plot is showing you is the frequency of silent Alzheimer's pathology by age. So people in their 50s have a very low rate of silent pathology. But by the time you get into your middle 70s and beyond, about a third of people have evidence of silent pathology. And we know this, okay? And so one of the things that's happening right now are trials looking at those people who have silent pathology and using the same exact drugs that are now approved by the FDA for use in people with mild cognitive impairment from Alzheimer's disease or mild dementia from Alzheimer's disease. And this is a trial that just closed evaluating Leqembi, in patients, in research volunteers who are healthy but who have a positive amyloid PET scan. And so this is a 4-year study. It will read out top-line results sometime in early 2029. So think about that, 2029, and it's right around the corner. And there's another study that may read out a year earlier than that. And so as early as 2028, you may have patients coming to you and saying, Doc, my mom died of Alzheimer's, and her mom died of Alzheimer's, and I'm 72 years old now. What do you think? Do I need to get tested? And right now, the answer might be, well, there's not really a whole lot we can do about it right now. But in 2028 or 2029, the answer may be completely different. So we have to think about, what are we going to do when that happens? And based on our experience with these drugs in MCI and mild dementia from Alzheimer's, I think these are going to work. I think by 2028, 2029, we're going to have readouts that tell us we can delay or prevent disease.
What if the patients are younger than 65? That's
Oh, well, in terms of the trials?
No, in terms of what you predict in the future. What if a 55?
Oh, I don't know when we're going to start screening. So, the rates of silent pathology is very low, but it's not zero. So 5% of our people between 50 and 55 have evidence of silent pathology. So I'm not saying that we should wait until 65 to screen with the annual wellness visit. We may do, what's the colonoscopy screening age now? What is it? 45. So maybe we take it down to 45. Or maybe we stratify it based on family history or ApoE status. Right now, we've been telling people, don't do ApoE testing because there's not anything you can do about it. That thing was fixed when daddy's sperm hit mama's egg, and you ain't going to change it, right? So what do you want to know that for? You could have the worst possible combination and might never get Alzheimer's. You could have 0 E4s, which is about half of our Alzheimer's population have 0 E4s, and they still got Alzheimer's. So yeah, we're going to, the answer to whether you should get those kinds of tests are going to be very different once we have evidence that we can actually delay and prevent disease. So ultimately, whether we're talking about Alzheimer's or other related dementias, we're really talking about the same problem. And the problem is, if you just got to mild cognitive, if we had a form of Alzheimer's disease that just got, there's a mild Alzheimer's case, it's just mild cognitive impairment, it never gets worse than that. No big deal, right? I didn't want to keep practicing medicine when I was 85 anyway. But the problem is it gets worse over time, and over a period of years, it gets to a period of profound impairment, whether it's Alzheimer's or any other disease. So the advantage of disease-modifying therapies is that everybody's going to die of something, right? And so if you drop dead of a heart attack at age 95 and your memory may be declining a little bit, but you're still functioning high enough to enjoy your kids, grandkids, great-grandkids, when you drop, people are good with that. The cardiologist loses, the neurologist wins, or their primary care doc wins, and everybody goes home happy. And then if we push that further to not just disease modifying, but disease preventing and delaying, that's how we get to the end goal, by empowering Liz and DPH and public health individuals so that we prevent disease rather than treating disease. I think we all recognize, you more than us as specialists, but you as primary care physicians, you know that the way to manage chronic disease is through prevention, not through treatment. So thank you very much, and I don't know how I did on time. Nobody was waving anything. So, all right, so do I have time